We are live, Madam Chair.
Thank you. Here we are back again in Senate Government Operations, and we are taking testimony on S-158. We have just had a lot of testimony, and now we are set to hear from Dr. Kim and Amy Gregory. I apologize. I just drank a glass of water. I don't know if either of you have a time constraint or how you want to do this. Who wants to go first here? I have Dr. Kim first on the list. So if you'd like to start us off, that would be great. And just identify yourself and where you're from. Thank you.
Well, thank you very much. Can everyone hear me okay?
Yes, thank you.
Well, thank you for allowing me to speak with you today. Please let me introduce myself. My name is Brian Kim. I'm Chief of Ophthalmology at UVM. I serve as a Shipman Professor of Ophthalmology at the Larner College of Medicine and also serve as a board examiner for the American Board of Ophthalmology, which is the governing body for continuing board certification for ophthalmologists. I've served as the Chief of Ophthalmology for 10 years now and have been at the university for over 15. The best part of my job at the university is being able to help people of Vermont. With regards to my training, after 4 years of medical school in St. Louis and 1 year in a medical internship, I completed 3 years of ophthalmology training at the Cleveland Clinic and 2 years of a combined medical and surgical retina fellowship at Johns Hopkins. As I'll speak about, I believe all these experiences important to safely perform surgery. I want to start by stressing that I firmly believe optometry provides a crucial and necessary role in providing primary eye care for patients who need it. And I also believe that this care expands well beyond just performing visual acuity tests, fitting glasses and contacts, as I believe some people feel to be the case. They are a vital and necessary partners in providing primary eye care in concert with ophthalmologists. I've worked very hard my entire career being inclusive and not exclusionary in my partnership, and I stress the word partnership, in the care of my patients. I consider optometrists as valued colleagues, and many I consider personal friends. Even with these personal and professional relationships, and because ultimately we are both dedicated to safe patient care, I have to make an important distinction. While I believe strongly that optometry has the necessary training to perform primary eye care, their training simply is not sufficient to perform surgical cases. In the new bill being put forward, the privileges being sought for include ophthalmic surgery. That's an important distinction that needs to be highlighted and clarified. To perform ophthalmic surgery, the providers have to be appropriately trained with stringent, standardized, careful oversight by surgeons with years of hands-on surgical experience in these fields. In their current curriculum and training, optometry simply does not have that. If you look at my training path I listed above, it seems like a long path, and believe me, it sure felt that way when I was going through it. While I accumulated over 10,000 hours in direct training over many years and performed more than 1,000 surgeries over that period of time, the most important part of my training was the manner in which it was undertaken. This is going to address Senator Polina, one of your questions about training. It may seem odd that I feel that 4 years of medical school would be necessary to be an eye surgeon. Those 4 years, however, were the foundation of everything to follow. To truly be a surgeon in any specialty, one has to have a base understanding of the human body and all the parts that contribute to patient care. I've relied on the skills obtained not only in the classroom, but also in clinical settings like the ER, the ICU, and general medical clinics many times over the course of my surgical retina career that have had direct impact on my patients. Safe surgery not only entails the actual act of lasering, incising, excising, more importantly, entails all the details of patient care prior and post-surgery that rely on an excellent font of general medical knowledge. To safely perform eye surgery on my patients, I then went through an additional 6 years of comprehensive, intensive training, which included didactic lectures, extensive literature and written study, but most importantly, actual surgical experience with real patients under the direct supervision of a specialized eye surgeon who had performed each of these cases thousands of times. This is a key separator of ophthalmologic surgical teaching from optometric teaching. While optometric teaching relies greatly on didactic lectures, literature, and written study, the actual performing these studies is generally via observation or on inanimate models or cadavers. There is absolutely no substitute for performing any surgical procedure, whether it's laser, injection, or incision on an actual human patient. So I'd like to share one of my very first experiences with a patient performing an injection. And to be clear, I'm going to talk about injection into the eye, which is not what they're asking for, but they are asking for the ability to do injections around the eye, which carries a similar risk profile. So my first injection happened fairly early in my career. in my training. To that point, I still had over hundreds of hours of lectures, of time in clinic, of a direct observation of all these procedures. I probably saw this procedure over 100 times. And I work with models as well. When you're early in your training and you haven't yet had the chance to work with patients in a surgical setting, as a resident, you'll work with a lot of different things. I work with a racquetball. I work with an orange. You'd be surprised at things you work with that you think are going to really emulate what it's going to be like when you actually inject or work on your first patient. And so with all these steps, I thought I was prepared. And again, I'd seen this hundreds of times. And to give you the scenario, so my first injection actually happened in probably the safest environment that could possibly be. Generally, these injections are on patients who are awake. They're not sedated. They're in the clinic. They're often nervous. They're moving around. They react to the injection by jumping or moving sometimes. My first injection was actually in the operating room. This patient was having surgery. So this patient was under general anesthesia. So they were completely asleep. They weren't moving. They weren't reactive. They were totally still. And I'm pretty sure that's why my mentor chose that patient for me, because that patient really represented the safest environment to perform your first injection. So I felt fairly confident. I felt like I practiced enough with models. I'd done all the reading. I'd seen this myself with my mentor 100 and more, quite a number of times. And so I knew the steps I needed to do. And so I stepped up, I followed those steps, and I did the injection. And I stepped back and I was pretty proud, I was fairly confident about, wow, I think I did a really great job. That was my first injection. I think that went pretty smoothly. What I didn't understand was, as soon as I stepped back, my mentor kind of jumped in front of me and put a cryo probe right in the patient's eye where I did the injection. Now that kind of surprised me because I thought I did a great job. But what I didn't realize was I missed my mark by about maybe a millimeter or so. And just think about that for a second. I just missed it by not very much. But what I didn't realize what I'd done, and that's still, I still think about that first case a lot because, the thing I think about is I didn't even realize what I had done. But by missing by a millimeter, instead of injecting into a space called the pars plana, which is a safe site for injection, that's an area of the eye that has no vasculature, so there's going to be no bleeding. It's got no tissues that you're going to interrupt with the injection. By going back just that millimeter, I actually injected the retina. And so what I did is I created a horseshoe tear or a tear in the retina. And if my mentor hadn't stepped in there and treated that patient would have progressed to retinal detachment. And again, what I think about this, and I still think about this case. I still think about this case because if he hadn't jumped in there, this patient would have a terrible outcome. So as you can see, while I already thought I had extensive training with hundreds of hours of reading, lectures, work with models, my sad little orange, and I really felt prepared, like I could do this. I could perform my first injection in really as controlled an environment as could be hoped for. The procedure definitely did not go as planned. And if I didn't have the proper oversight and the immediate treatment of the issue that I myself had caused by an experienced surgeon who had thousands of these procedures under his belt, this patient would undeniably had a poor outcome that could very well have been permanent. Now, this patient did great because he responded so quickly. Now, if he didn't, though, this would have led to retinal detachment, which is one of the most significant vision-threatening consequences that can result in blindness, even if you repair it surgically. And this is why the ophthalmology model of surgical training is so vital to perform even what's been called, quote, simple surgery. There are no simple surgeries. The reliance of ophthalmology surgical training on work with actual patients with a surgical senior mentor directly overseeing every movement during surgery is repeated over and over and over again for each procedure we learn to master. There is no substitute for this method, which further also relies on a national standardized registry to demonstrate the bare minimum required. Now, I've been part of efforts myself to develop artificial intelligence, AI, or virtual models aimed to supplement the experience obtained by working with real patients. And I can also say with certain that even the most advanced AI models do not simulate real patients at this juncture in time. They really can only be used to successfully in conjunction with or to augment and not replace real surgical patient experience. So the current bill for optometry performing ophthalmic surgery proposes a minimum of 32 hours of training, observation, and practical work with models to be sufficient to perform some of these tasks. As I know from personal experience, and more critically from my own failures and my own setbacks, that's not nearly enough time, nor with the actual human-patient interaction necessary to perform even what has been called simple surgery. Laser, incisions, excisions, all are significant events which can lead to permanent alteration and, quite honestly, controlled destruction of human tissue. And all these things can lead to permanent vision loss. I'd also like to say that the bill in front of you is different than the one in 2019. In the 2019 version, the bill was more inclusionary, i.e. it spelled out specifically what procedures were being sought out. With an inclusionary bill, there was much more specificity, given that each procedure being asked for could be specifically vetted for appropriateness of training. There would be no gray area as to what could or could not be performed. The OPR study that was a result of this bill stated that, quote, OPR cannot conclude that optometrists are properly trained in and can safely perform the proposed advanced procedures. Further, the proposed advanced procedures, if performed by untrained individuals, pose risk. So it poses risk to the health and well-being of the public. This new bill is exclusionary in nature. While it still allows for the very same procedures asked for last time, such as lasers and removal of benign lesions, it also specifically excludes procedures including any surgery requiring incision of structures, including the iris, vitreous, and retina. So at first glance, while it appears that the exclusions would limit significantly what privileges are being requested, it really does the opposite. With the exclusionary list as requested for in this bill, the number of procedures that optometrists might perform is exponentially larger and would constantly change as research develops new technology procedures. The exclusionary list would also make confirming that the training aligns with the scope and authority much more difficult. Thus, this new bill appears to be significantly more impactful and broad than the last. Importantly, not enough time has passed since the OPR study to indicate that optometric training has changed significantly enough to address OPR's past conclusion and concern that optometry has not demonstrated that they have the necessary training needed to safely perform the procedures being asked for in this new bill. This is not the first time, as you all know, that optometry and ophthalmology have come before the state to discuss the delivery of care to the people of Vermont. I want to end again by referencing the OPR report just completed. In delivering primary care to the people of Vermont, OPR concludes, it is not clear to OPR that the proposed advanced procedures are, quote, simple and part of primary eye care. They further state that past assertions by the Vermont Optometric Association, who represents the optometrists of Vermont, also did not always consider these procedures to be primary eye care either. During the 2003 Vermont Optometric Scope Expansion Report process, the Vermont Optometric Association, again, who represents the optometrists of Vermont, asserted that surgical and tertiary medical eye care went beyond primary eye care. Now, while much has changed and advanced in that period of time, what has not changed is the basic lack of surgical training and direct surgical patient experience offered by the optometric curriculum. In the over 10,000 hours of training I've received, I would say that without direct surgical experience on human patients, I would not feel safe performing surgery. I share the story of my own failures in training to highlight the need for standardized, hands-on oversight by experienced surgeons. The risk to patients, and in this case, the people of Vermont, is just too high. I would ask you to please consider the data and the conclusions of the OPR study just completed. Nothing has changed dramatically in the training of optometrists that address the basic concerns of the safety that we are all here to protect and uphold. Again, I have nothing but the deepest respect for optometry and in particular, the optometrists in Vermont. While we work together to deliver primary eye care to all our patients, that should not include advanced procedures, especially in the exclusionary manner they have been requested for. So thank you very much for your time. I'm happy to take any questions.
Thank you. I think we'll do the same thing that we did before. Is we'll hear from Amy Gregory now, and then Amy, I'm not sure, Ms. Gregory, I didn't print out the agenda, so I don't know who you represent. So if you want to identify yourself, and then I'll see if I'm right about the way we question.
Sure. Okay. Good afternoon. My name is Amy Gregory. I am the immediate past president of the Vermont Ophthalmological Society and board member of the Vermont Medical Society. I am an eye physician and surgeon from Middlebury who has practiced comprehensive ophthalmology for over 20 years. I perform cataract, glaucoma, eyelid, and laser surgeries. I am here to testify in support of maintaining the highest patient safety standards for surgical eye care. As Dr. Kim mentioned, in early 2020, the Vermont OPR completed a very thorough, well-informed study addressing proposed optometric expansion to include advanced procedures eye surgery. This very extensive study and subsequent final report was clear in its conclusions, Optometric scope expansion to include advanced procedures is unnecessary because patients' eye surgery needs are currently being met, and not recommended because optometric training in eye surgery was found to be non-standardized and inadequate. After OPR submitted their report concluding that this proposed scope expansion was not in the public's best interest and definitively recommending against it, a number of optometry schools contributed additional information on their educational programs, including more detailed course descriptions. Review of this additional information showed no new evidence of appropriate surgical training. OPR's position and conclusions remain unchanged. Optometric scope expansion to include surgery remains unsupported because current optometric training for eye surgery remains inadequate. Training on lasers and surgical instruction is not standardized among optometry schools and varies from state to state. The lack of hands-on, real-life procedural experience in the vast majority of current optometry schools is a very serious concern. As an example, laser eye surgery by non-ophthalmologists, non-MDs, is only legally allowed in 2 states with optometry schools, Oklahoma and Kentucky. You have already heard about the Oklahoma program at length. In Kentucky, the laser course objective states that students demonstrate an ability to perform simulated laser therapy. So laser training on a live patient is not a requirement, even in a program whose state authority allows optometrists to perform lasers. What about postgraduate training for optometrists who are not recent graduates and may be well along in their professional careers? The proposed 32-hour postgraduate optometric education courses purporting to cover an extensive list of surgical procedures in a long weekend are wholly inadequate for surgical training and involve 0 hands-on experience with live patients. Are simulated procedures and lasering model eyes adequate surgical training? Do continuing education courses of any hourly length qualify an optometrist to perform eye surgery without any real-life experience? Does optometric board certification for lasers and procedures turn an optometrist into an eye surgeon when they have never performed a single procedure on a living patient? The answer to all of these questions is no. It's critically important that a surgeon have extensive procedural experience with living patients. Living patients talk, blink, cough, tear, bleed, faint, and sometimes curse because they feel pain. They squeeze their eyes shut. You can't make them hold still while you are performing a laser. They make sudden movements when you do anesthetic injections in their eye or in their eyelid because it is a hurtful experience. If you've never performed surgery on a live patient, how can you possibly know how to handle the unexpected, the complicated, the complex? If you are an ophthalmologist, you know because this is an integral part of your training. As Dr. Kim mentioned, ophthalmology training involves one-on-one mentored progressive surgical exposure with qualified oversight over a period of 3 or more years, just for surgical training. Surgical skills are not only taught, but they're continuously assessed and closely monitored by experienced attending physicians and surgeons in a hospital setting. Medical doctors who graduate from ophthalmology training programs must demonstrate appropriate clinical judgment, competence, and proficiency in performing eye surgery. If you review the optometry school course descriptions for laser and surgery training, you will see repeated use of the words observation and simulation. You will see that training for injections sometimes means practicing on fellow students. Training with scalpels and sutures is done on artificial skin. You will see laser and surgical courses taught by non-surgeons. Most eye surgery is not a life or death situation, but it always carries a potential risk for visual harm. Would you want a provider with no real life prior surgical experience to put a needle in or near your eye or laser it? If you believe, as I do, and as OPR has already concluded, that this bill poses any degree of unnecessary risk to the safety and welfare of Vermonters' eyes, then you must oppose it. Thank you. also happy to take questions.
Thank you. So committee, does anybody have any questions to start off here? I have a couple, I guess. Yes, Senator Clarkson.
I apologize. I was in Senate Appropriations and missed so much of this first important testimony, and I'm really so sorry about that. So if this question was asked, please just let me know. But Amy and Brian, I'd be interested to know how many hours of training you is recommended for each of the procedures that are recommended in this bill.
So maybe I can start with that, Senator Clarkson. The hard part about this is we don't know what's actually been asked for because it's exclusionary. Only things that have been asked for are there's 17 procedures that they've said they don't want to do. That leaves open the door everything else. So I'm not even certain and that's part of the issue here. We're not really certain what they're actually asking for. The 2019 version was very specific. They asked for specific lasers, specific procedures like benign eyelid procedures. So it's hard to answer.
Why don't you take a couple of those and give us a notion of how much time, how many hours of training would be required in an ophthalmological training environment?
Yep. So because of the way that we do it standardized, it's not actually the hours required, it's the number of procedures. So there's a set number for procedures for graduation, each of the procedures that is required. And honestly, the first laser I did for a diabetic laser took me at least an hour. And then you get progressively better and better over time. So it takes less and less time. So the more important number is the actual numerical number versus the hours. And Amy, you can feel free to also add to that.
Well, I'm trying to get at the 32 hours. You keep despairing about the 32-hour training, which you say is wholly inadequate. Okay, so how many hours of training would an ophthalmologist have for the same procedure? That's what I'm trying to get at.
Sure. Yeah. So I wasn't even allowed to touch a laser patient until it demonstrates multiple steps. So 32 hours wouldn't even take up the amount of time that I was required to get comfortable putting the lens on a patient's eye, doing the exam to do the patient's eye, much less press the button that would actually deliver thermal power and thermocoagulate irreparably parts of their vision. So it's hard to give a numerical number. But I'll tell you the graduate course before I was even allowed to touch a patient and do a laser was way more than 32 hours.
Well,
I also think it's very difficult to put a number of hours on appropriate training to do procedure X when the learning of the entire surgical process, including lasers, it is a process, it is a program, it is an educational package. It is not, if you go read these 2 chapters in the book and watch these 5 videos and then practice this much on the laser, it is a process that takes place over an extended period of time under very close supervision by experienced surgeons. So I'm not sure that you could, it's very difficult to answer that question to say, oh, if you want to do this type of laser, you should have this many hours of practice. Or if you want to do that type of laser, which might be a little more risky, you should have this many hours of practice. That's a very difficult question to answer. And I don't know that there is a definitive answer for it.
so we're being asked to sort of compare apples and oranges.
Well, the hard part
Slightly,
also,
yes, I think that is a good analogy.
and the hard part about that question too, Senator, is that 32 hours is a comprehensive 32 hours, which is not just patient care. It's 32 hours of combined lectures, videos, working with models. So it's not actually 32 hours working on a patient. If you take my example of where I completely failed doing my first injection, I had hundreds of hours of prep for that one injection, which I totally failed at doing that first time. And so again, I think it's the necessary time of learning just everything around the injection or laser or incision that's important.
And your 6, may I just follow up, Madam Chair?
Yes.
Thanks.
Mhm.
Your 6 years of residency, which is, I assume, what you were talking about, the 6 additional years in ophthalmological training, was that entirely in ophthalmology?
No, so that was so there was the 4 years of medical school. And then after that, I did 1 year of medical internship,
Right.
3 years of ophthalmology training, 2 years of surgical retina and surgical and medical retina. So 5 years dedicated exclusively to the eye, 1 year of medical internship following my 4 years of medical school.
And practice makes perfect. So, I mean, if you're doing surgeries and training to do surgeries all the time, that's I guess what you become expert at is surgery.
Senator Collmore, I'm sorry, did I cut you off?
No, I was just going to make the comment that practice doesn't actually make perfect. Practice improves skills and practice improves safety. I think seeking perfect
Right.
when it comes to medical care is a difficult.
Yeah, no, I didn't mean to be glib. Of course, it
No.
doesn't.
I think
Senator-
expertise is the key.
I see Senator Collmore had a question.
Thank you, Madam Chair. Yeah, I'd like to go back, and I believe it was Dr. Hitchmont that was testifying, and I just copied down quickly a note. And if I mischaracterized what you said, I apologize. But I think if I said that you felt that there were some issues with OPR's report, if I could just get you to sort of outline what some of those issues might be.
Is that a question for me?
I believe it was you, but
Yeah, I did reference it.
Okay,
So yeah, some of the inaccuracies in the report, and let me just step back because I want, in the end, both professions have to work together, and it's critical that we work together in rural counties. And just because we disagree doesn't mean that optometry doesn't respect the surgical training of ophthalmology. Let me just be clear about that. And I don't fault them for not understanding the depth and breadth of our training because they didn't go through our training program, right? They went through their training program. I'm here to attest that the OPR report had significant inaccuracies in it, to include the fact and implication that there was nothing in place to test competency for invasive procedures, that there was no experience touching patients, and that there were only 2 states in the nation that actually provided for that training. That is absolutely not factual. I'm happy to read directly from the curriculum or from the affidavits provided from all 23 schools and colleges of optometry that affirm that the training takes place for these advanced procedures that we're talking about. And we can provide written information in that regard if that would be helpful to you, Senator. I would also add that when optometrists or any doctor learn a new procedure, they're building upon experience that they already have as a doctor. I was in a hospital for 22 years. I've been in practice for 26, actually. I think I said 25 earlier. I have had patients pass out in my lap, throw up on my shoes, face plant in the hallway, and have heart attacks in the middle of procedures. We all are aware of the dangers of being human in the medical setting, outside the medical setting. And it's not as though we don't all have that training as a core part of what we do, right? Again, I will not, and I don't think we should fault ophthalmology for not understanding every single portion of every single state law and every single school of optometry. I don't fault them for that at all. This is not their fault if they've been given inaccurate information by OPR, but I would respectfully request, as I did in my testimony, and I know that Senator Clarkson wasn't on for that OPR go back and look at its report and go back and look at the report that I provided 22 or whatever years ago and just correct some of the inaccuracies, right? I mean, it's just, for me, it's disheartening to hear that, to hear the implication that optometrists would go out after sticking a needle into an orange and then, randomly just going out into the public without proper supervision, surgical invasive procedure, whatever you want to call it. We're not asking to do cataract surgery, right? Operating room procedures in this bill, just to be really, really clear. We're not looking to be mini ophthalmologists. We think ophthalmology does their job best. We think we do our job best. And, I think it always is helpful for you to have the right information to make the best decision about what's safe for the public. And I know that that's hard, and I'm sorry that's hard, and I wish we had more consensus.
Thank you, Doctor.
So I am going to go out on a limb here, and I was in this committee when the optometrists asked to, and I don't even remember what it was now. I think it was prescribe medications and treat glaucoma. I think that's what it was. And we heard the same fears then, that they weren't capable of doing it and there would be harm to the public. So it always makes me nervous when somebody wants to, and I'm not saying they want to increase their scope of practice, but rather want to practice their profession within what they've been trained to do. And there's disagreement on whether they actually have been trained to do that or not. So I see this all. So I'm not sure that when we changed that years ago, that there was great harm to the public and that people were suffering. So, and I don't know in those states where this is allowed, I have not heard that there's been harm to the public. And if somebody can show me that has happened in those states, and that that optometrists are making mistakes and are having accidents or whatever, then I would listen to that, but I haven't heard that. So I just, yes, Amy.
I think if you look in the OPR report, you will find that they did address that concern and addressed claims that there, were no reported adverse events and nothing wrong has ever happened and no board reports. And I think there were some discrepancies in between some of the reporting from the state board. So I would just encourage to look back at the OPR report on that particular detail.
Oh, I will. And I'm not saying that there's never been a mistake or there's never been a bad practice, but that would be true in any profession and any level of profession that, I mean, we know that there are times in hospitals where the wrong leg gets cut off. So it isn't, I mean, those kinds of things happen because doctors are not gods, they're people. So anyway, Dr. Hitchmuth, did you have a comment?
Only if there's time. Relative to that,
I have no idea what time it is.
3:35.
Oh, we have time. And I want to make sure that committee members get their questions asked and stuff. And I will say, we are not going to complete this today. We have more committee discussion that we need to do. And also we need to hear from Lauren. And I don't know, Lauren, if you want to comment today or if you want us to keep asking questions and then
be flexible, Madam Chair. I'm here. I'm able to testify today. I can wait until another day. But I do recognize you have quite a few experts in front of you, and probably this would be the best time to get your questions answered from them, and they've dedicated the afternoon. I'm happy to come back anytime.
Thank you. We know where to find you. Yes, thank you. So I'm going to go to
one question before she goes.
Oh, I don't think she's gonna go.
I'm,
Oh,
I'm,
okay.
I'm not, I'm
Oh, I
here.
thought. She's just not gonna we have her on the list to testify to us, but I think she's right that we have all these people here who have given us their time this afternoon, and we should make sure that we get all our questions asked of them so that they don't have to give up another afternoon to come to us, because they're all very busy people. So, Dr. Hitchmuth?
Yeah, I think, Madam Chair, and to clarify or support this statement that you already made, I always try to find the best source of facts regarding malpractice and harm. And so the largest insurer of optometrists in the country is Lockton Affinity. And this is actually from a letter which we can provide. It says, "Thank you for your inquiry regarding malpractice insurance rates for doctors of optometry." And I'm slightly paraphrasing, but I'm going to give you the whole thing. The rates currently being charged by two doctors of optometry reflect the scope of practice in their state. And the current locked-in rates for states who have updated their laws has not changed with any significance. So for example, the malpractice rate in Oklahoma, Kentucky, Alaska, and Arkansas, all which have similar advanced practice laws, all have a rate that is very similar to what we have in the other states. There was implication in the OPR report that those details were not teased out, and therefore we were just spreading out the liability to states with advanced scope versus not. And so I would just encourage the committee to allow us to submit that information. The insurance companies indeed would make it clear to us if there were problems being reported on the malpractice front.
Yes, if you could somehow submit that to Gail, and then she'll give it to us and put it on our website. That would be great. Thank you. I saw somebody's hand there. Oh, Dr. Kim.
Yeah, sorry. I mean, just as something I heard during testimony, I think it was, and also something you mentioned as well. In the OPR report, what's interesting is, is what also Dr. Clarkson said, any procedure, there's going to be complications, no matter what. No matter how simple they are, there's going to be complications. If there's an oversight by optometric board, I go back to the OPR study, which queried the executive director of the Oklahoma board, who reported that there were been no reported adverse outcomes reported to board examiners by any optometry patient between 1992 and 2019. So over a 30-year course history, there was not a single report of adverse outcome by a patient in Oklahoma. Yet, if you look at the malpractice payments that were paid, 59 payments were made during that time. So that's problematic in two ways. First of all, it's impossible to have a 30-year history of procedures with no complications reported. Secondly, the fact that there were 59 malpractice payments made during that same period of time tells me that the oversight is not as locked sure as we would want it to be.
So maybe we could get some information on that discrepancy and why that exists. Thank you. Anybody else? Yes, Senator Hinsdale.
And this might be a question for Lauren, but I guess it comes from a place of feeling like it's a huge responsibility for us to be the arbiter of this decision. And, OPR is not a medical board necessarily either. There is the Vermont Board of Medical Practice that maybe we could hear. I just feel like there's a medical arbiter of this decision, and we're not really well qualified to be the 5 people who make this determination.
Unfortunately, we are, because there's always that difference between people who want to expand their scope of practice or do more, and people who don't want them to do more. And that that happens in every profession that we deal with in here. And unfortunately, we are, because the Vermont Medical Board is the Vermont Medical Board, and they have clearly stated their opposition
Okay.
Vermont Medical Society.
Okay, not the Board of Medical Practice.
No, and I don't know. Dr. Kim, do you have?
I do. So actually thank you, Dr. Rumford. So that, Senator Rump, that was actually asked of the Board of Medical Practice. So the Board of Medical Practice was asked this question in November of 2019. The response from the executive director of the Board of Medical Practice stated, quote, "There is no evidence of justification for accepting greater risk on behalf of Vermont patients. The evidence shows no problem with access to care for the procedures at issue. The BMP noted the vast differences between ophthalmologic and optometry education and training and the risk posed by surgical procedures on eyes. The BMP also noted that there is less information available about the adverse history of optometrists than there is about physicians who are often required to report adverse events." So they have weighed in on this in the previous bill.
Mhm.
I just wanted to have that information. Okay.
Yeah, thank you. Yeah, please.
Well, okay. I mean, I'm sitting here thinking, what would the Health and Welfare Committee do? Because what I'm hearing are things that remind me, even if it's very tangential, of, midwifery or, nurse practitioners, or where what I feel like people are arguing is that optometrists might not be in the right medical setting in case something goes wrong, more than they might not have the requisite training to do this work. Maybe I'm hearing both, but I just feel like I have not been on a committee where we've dealt with sort of the questions of what makes a Vermonter unsafe in a particular medical situation and what is our role and responsibility. I'm trying to figure out, how we ask the right questions as a committee that doesn't deal day in and day out with healthcare related matters.
Yeah, it is challenging. I really think that the question is around the training and the education and the training and the competency. And I think, and the ability to show that competency. I think that that's where, because my guess is, and I'm not sure, but I know my husband just had cataract surgery, and it was in an office. It wasn't in a hospital setting or anything. It was, you're shaking your head. It was in the doctor's office.
Then it was an ambulatory surgery center in an office. I mean, it's not done in, cataract surgery is not performed in an office setting. It's performed in a surgery center or a hospital, an outpatient hospital setting.
Oh, I don't know. It was in a mall in Keene, and it looked like an office to me, but yeah.
Maybe YAG.
They do.
In New York, I'm sure.
Mine was done at Mount Escotney Hospital.
Right. I don't know, but they're not asking to do cataract surgery.
No, they're not.
So they're asking to do minor surgery. And although it's called advanced practices, it is not advanced to the degree of an ophthalmologist. The ophthalmologists are still the ones that do major surgery on the eyes. That's the way I understand it, that there's no request here to do those kinds of major surgeries. Am I right about that?
So again, the way the bill is written, they just exclude some major surgeries, but there's still a number of surgeries out there that have not been specified. So we don't know the true ask of what's being asked for. They've only limited 17 procedures that I guess they categorize as major surgery. But to be clear, all the things they talk about, like laser, incisional surgery for a biopsy removal, it causes permanent change to human tissue.
Senator Clarkson?
No, I guess so in this bill, we aren't naming the specific surgeries that we would be, if it's exclusionary and it excludes a whole bunch of are we, I thought it was specific about the surgeries they were asking permission to be able to do in Vermont. It isn't? I thought it was.
I think my understanding is that the bill in 2019 did that. It asked for the specific ones.
Yeah.
And
so I
there was opposition to that bill. So it was rewritten to be exclusionary. It could be both.
Yes.
I mean, it could be both. This is what we're allowed to do and this is what we're not allowed to do.
So that may be a more productive avenue to go, is to identify the surgeries. And you could even do it, phase them in and see how they go and add more as time goes on. If that was, I mean, if that's one of the major concerns, is that they're not identified. I know your major concern is the time and training, and I understand that, but it strikes me that they've made a lot of movement towards trying to clarify practice and scope of practice, and they have, so anyway, that might be a way to go.
So I guess is Senator Polina?
So this first thing I'm going to say is repetitive, but I just wanted to sink in. When we went through the bill and Amran was having a hard time pronouncing all those things, those are the things that they're saying they don't want to do. What's listed in the bill are things they don't want to do. So given that, how many other things are there that they might find themselves doing? Is we talking about 6 things, or are we talking about 600 things? I mean, what are we talking? I mean, give us an idea of the scope of what they would be allowed to. I don't mean particular procedures, but is it just a couple of things they'd be able to do, or a bunch?
Thousands. Yeah, now at ophthalmology, we perform thousands of different types of procedures. If you're not specifying, if you're only excluding 17, there are thousands out there that could be done.
So I could do procedure A, B, C, and D, E, all those, but there's no way to guarantee that I've gotten education around those A, B, C, and D.
Well, the list could be both inclusionary and exclusionary. I mean, it could be.
But I would think in the perfect world, if I'm going to do procedure A, there should be a course that I take in procedure A,
Right.
so that I'm qualified to do it. If I want to do procedure B and C, there should be a course I take that allows me to master B and C. And I don't see that. I don't mean to be, I don't mean to be biased about this. I mean, I'm open to the discussion, but I just don't understand how I could be allowed to do surgeries that there's no way of knowing if I'm trained to do them. It just seems kind of weird.
Well, I think that's where the crux of it. And I think that's where the difference of opinion is. The optometrists and the credentialing agency and whoever these people, the people are that we heard from the Veterans Administration, they all say the training is adequate for the things they want to do. On the other hand, the ophthalmologists and the medical society say it's not adequate. So I think there's a difference of opinion here about whether it's adequate or not. And I think that's, in my mind, that's the crux of the whole issue.
I agree.
Yes, I'm going to go to Dean. Did you have a comment?
Yeah, I mean, in our conversations with Lauren, one of the things she kind of talked about are where are the bumpers? And the 17 things that are listed that we don't do are not 17 specific procedures. They are 17 areas that are bumpers. So we're talking about any retina laser procedure, any penetration of the cornea, any administration of general anesthesia, any surgery done under any general anesthesia. Very few of these are specific to a surgical procedure as much as they are saying we are not going to touch that area. And I think that's probably a mischaracterization to say we have listed 17 things When you say we're not going to do surgery of the extraocular muscles, well, there's 6 per an eye. That is a whole grouping of procedures that happen to help with eye alignment. When we say we're not going to do surgery of the bony orbit, that includes the bone around the orbit, but that is all encompassing for many surgical procedures. The other thing that I wanted to put in place is what I said earlier, which is that it is still malpractice to do things that you're not educated to do. And the truth is, there are 2 bumpers to me right now. One is the state law that says I can or cannot do specific things. And the other is my own personal ethics when I am in the room with the patient. And again, we have to come back to the fact that you're dealing with professionals here. You're not dealing with people who are sitting back trying to figure out how to sneak one by. The third thing that I would like to put in place is I would like committee members to remember that there are 7 other states that have this full scope already in place. And in all of those states, I'm looking for my notes here, which I don't seem to have. So Alaska, Arkansas, Kentucky, Louisiana, Mississippi, Oklahoma, and Wyoming, and that was current as of November. There may have been some movement in 2 other states that I'm not completely sure about. There are other states where this is happening, where the training is adequate and it is put together. We've talked a bunch in the last few minutes about the OPR report, and I don't want this conversation to be about the OPR report. The state of all states have some form of sunrise format where states sit down and they look at the potential scope expansion. Just this year, Washington and Colorado, the equivalent of OPR in those 2 states have just released reports that show the polar opposite of what our Vermont state report had. Lauren has been wonderful. She has worked with us and she's talked with us about the spaces that we're going to get in trouble and things that she would like to make sure she sees so she can operationalize this. When we came into this, she has said she is neutral on this and she would like this to be a legislative policy decision. We have provided pages and pages of documents since the OPR report came out. I have to be able to work with everybody. And I'm not looking to be in a space where we are really targeting one side or the other. I would just like to look at the facts, and I would like to be able to work through and get to the end so that we can get this bill passed. And I'm happy to answer questions on the way through. I'm happy to provide the 2 reports, the 2 sunrise reports from 2 other states, Washington and Colorado, to this committee so that you can review them side by side with our own report and come to your own conclusions.
So may I ask you if you would, or maybe Dr. Castillo, since he's from Oklahoma, Brian Kim brought up the issue of the discrepancy between the report that there were no charges, I guess is the word, that's not exactly the right word, but there were 59 cases of malpractice payout, or I think they're malpractice payouts or settlements somehow. So if you could find out why that discrepancy exists, is it because they ended up not really being malpractice, but I mean, it didn't rise to that level, but there was a settlement because people didn't want to go to court. I sit on the Judiciary Committee, and boy, we hear all about settlements before anything ever happens. And I just want to make sure that we understand why that discrepancy is there, because that, or if it is a lack of oversight.
Well, can I speak to that?
Do you know the answer to that?
Well, I don't have perfect information, but I have a few comments on it for sure. You know, in my office over time, there have been 2 times where my medical malpractice paid out. One time was because a patient got a pair of progressives and they claimed that they caused them to fall, and my medical practice paid out $800 to make a case go away. The other time was this very convoluted moment where I was on vacation and a patient requested a letter be written for disability, and my father pulled the chart and wrote the letter, and the patient claimed that our office had violated HIPAA because the doctor who had written for the record, everybody, my father is also an optometrist and I work with him in the same practice. So my father, trying to expedite this, wrote a letter of disability answering all the questions and sent it off. And the patient felt that we had violated HIPAA because the doctor in the practice who wrote the letter was not me. And medical malpractice paid $1,000 or something like that. So just because there is a payment that goes out does not mean, in fact, that it is a payment because something untoward happened. I think it's important to remember what Dr. Hitchmoth said, which is you need to look at per capita, the number of malpractice against a particular profession. You can't just pick a number of malpractice cases against optometrists and say, there, you have it. There were 44 people who were potentially harmed. I think you've got to look at it in totality as the whole picture.
Yep.
The other thing that I would say is I think an informed, logical decision on that would be rates. Individual cases are anecdotal at best without the details, but rates for the provider are going to be the drivers of true risk.
That's why my primary care doc stopped delivering babies, even though he was really very good. It was only the insurance rates. Anything else that we can, I'm not sure if there are other questions that we need answered, or where we go next. I think we need to really, as a committee, have this discussion and meet and hear from Lauren. And I don't know, committee members, if you want to hear from Lauren now, or if you want to, I, again, have no idea what time it is.
It is almost 4 o'clock. And
okay.
I'm hesitant to ask questions because I'm worried they've been asked already.
So maybe it would be helpful if we scheduled this again. You watched the
Yes.
first part of it so that you heard that. We've asked questions here. I'm certainly not going to ask you all to come back, but would welcome you if you want to. So as much as we'll send you all an invite the next time we do it, just in case you want to come back and you want to be available for more questions again after we talk to Lauren and have some committee discussion. Or if you, so does that make, I said Senator Clarkson had her hand up.
Yeah, I think Dean's point about population is important. 59 malpractice payments is nothing in a state of millions and millions of people. I mean, you're right. It's kind of an out there thing, but do we have, and forgive me, I just don't know because I didn't see it quickly. do we have the sort of the success records of all 7 states? How many optometrists are using these practices? How many perform them on a how many are practicing in each state? How many do these expanded scope of practice, and how successful they've been? Do we have that in a chart? Because I just didn't see it. And again, that may have been asked, and I apologize.
No, I don't think it was. I think that we could ask that. I guess the question is, the major question is, has there been any harm?
Yeah, and I guess that would be part of what we would find out from these 7 states, because 7 states have been doing it for different lengths of time. The longest is Oklahoma, from what I can remember. Is that right? 30 years? Some of these procedures haven't been around for 30 years, have they? Anyway.
I think it's in the mid-20s, and you are correct. Not all of those procedures have been around that long.
Right. So I think it would be helpful for us to maybe see some of those other Sunrise reports. I mean, if Washington and Colorado did them, I think it would be helpful for us to see the success record of the 7 states. I mean, so that we, and get an understanding of how they've been, and hear how the relationship, how it's worked, because you guys are partners, optometrists and ophthalmologists. Mine practice together. So I have a seamless, Chris Connor and Peter LaPrey practice together. So, I mean, I'm lucky. I just, and their practices mesh kind of perfectly. So it would be, that would be helpful. Sorry, Brian, I know you had.
Yeah. Senator Clark, I can answer that last question you had. So we can provide you with a study that showed, I believe it was Oklahoma, Amy, correct if I'm wrong, but the study was performed that showed that the need for a certain laser procedure performed by optometrists was double the rates of an ophthalmologist performing the same procedure. So we can show you that study. So there are things like that out there which suggest that for when a laser is being requested, wouldn't fall under this bill. The rates were double when done by an optometrist versus the amount of surgeries done, the amount of times it would need to be done.
You mean the cost?
No, not the cost. So the number of times procedures performed was twice the rate when done by an optometrist versus an ophthalmologist.
And is that because they were more accessible? I mean, that's not.
It was so the same endpoint was reached in one treatment from an ophthalmologist versus 2 by an optometrist, and each of these procedures are charged for. So
are they much less expensive?
No, they're performing double the same procedures performed in the amount of time an ophthalmologist did a procedure once. It took the optometrist multiple times to get that same endpoint.
Oh, that's not how I understood what you just said. I thought what you said was optometrists were doing double the number of laser surgeries than ophthalmologists in Oklahoma. That's what I heard. I'm sorry.
No, I'm saying for a particular procedure, for success, an ophthalmologist did it once. The same procedure, an optometrist had to do it twice, double the rate. So they're doing for that procedure. And
I mean, they had to do one, and then it wasn't successful, and then they had to do it again.
Correct.
Oh, and Dean, did you?
Oh, I would love to talk about this study. So what we're talking about is SLT, which is a laser treatment used to lower pressure in glaucoma. When we look at standard of care, there are guidelines that are put out. So the American Optometric Association has some, but ophthalmology also has some, and they're called preferred practice patterns. And even to this day, if you look at the preferred practice patterns for SLT treatment, you'll find in there that it is recommended that you treat half of the eye first, 180 degrees, and then you wait, and on a subsequent day, you do the other half to make sure that you don't have an inflammatory response. And so when this study was done, it was right after optometry started doing lasers in Oklahoma. It's an old study, and it's a favorite that is brought out. But optometry being recently allowed to perform these procedures was doing it by the book. At the time, ophthalmology was doing 360 degrees in one fell swoop. And this is pointed out to be evidence of poor performance by optometrists. Additionally, within the study, there was no control for race, which is crucially important when you're putting lasers into the trabecular meshwork. Because the amount of pigment matters. The study has plenty of problems, and I would love to give you data on it.
I would also, I would like to have a clearer, and maybe somebody can write it up for me so that I can actually read it and see it, about this famous 32 hours, because the way I understood when Dr. Castillo was talking about it is that it isn't the only training, that there's training, and then this is a review. This is 16 hours of review on the laser course, but you've already taken the training and the course, and this is a review. So if somebody could just write this up for me so that I can read it and try to wrap my head around it, that would be very helpful. And Allison, you missed that whole thing. So did you have a question?
Yeah, I mean, because I think one of the issues here is I can see ophthalmologists, I mean, independent of all the other things, but I can see ophthalmologists being concerned that optometrists would eat into their business, which I get from a business point of view. And I guess my question is, in those 7 states, have the ophthalmological procedures maintained themselves, or are they in fact being eroded by the optometrist's ability to perform some of those? Has it liberated the ophthalmology departments to doing more and more complicated surgeries? And so has it given them more time to do bigger, more expensive procedures? So I'd love to know the cost difference in the 7 states between what an optometrist charges for one procedure and what an ophthalmologist charges for a procedure. So, I mean, those are some of the questions, I think, because I get that a business wouldn't want to have their business eroded by another crowd. I get that, but I think we should see if it's in fact happened in those 7 states and what the cost difference is and what's actually sugared out.
We can look at that, and we will have, I'm sure that can be presented to us. My concern with that is that we shouldn't be concerned about people's business plans, whether they go in or out of business, whether they're successful as an entrepreneur or whether they're working for a hospital. That shouldn't be our concern. Our concern is there adequate training so that these procedures are safe and don't harm the public? I think that that's our bottom line. If it eats into somebody's business, I don't think that's our concern.
Well, it may, we've been looking at intent for our ethics bill. I mean, it goes to other aspects of things, but I guess I would ask in this, which is, I just lost my question. It will pop. It'll pop. Sorry, it just totally evaporated.
To me, and this may be different for everybody, but to me, the basic question is, when a profession has the education and the training, should they be allowed to practice that, to perform what they've been trained and educated to do? That, for me, that's the only question here, is because I have no interest in protecting anybody's profession or I shouldn't have said it that way. I do have interest in but that is in my mind, that's the only question that we need to ask is, are they adequately trained and educated to perform this? And if the answer is yes, then they should be performing it. If the answer is no, then they should not.
So, Madam Chair, I remembered, of course, the minute I actually thought about things, I remembered it. And it goes back to something we talked about very briefly, which is, might the parties be amenable to phasing in procedures so that sounds like it would make the ophthalmological community more sanguine with this bill if we identified the procedures that the optometrists want to do. And let's say you identified, I mean, I'm just being arbitrary, but let's say you identified 20 for the next 2 years. And then if those were, we could just then phase them in. But it sounds like naming the procedures is that we almost went too far in the other direction, because without naming the procedures, you don't know what the training is required. You don't necessarily, do you see what I mean?
Well, I think that is, my guess is that is something that probably would not, I can't say, be acceptable, because I think there is a basic disagreement here about whether the training is adequate or not.
But if we haven't identified the procedures, and I think that's what I'm understanding, is that we have not identified the specific procedures, how do we know that the training has been inadequate?
We haven't, we've identified apparently 17 areas, not 17 procedures, 17 areas that
are
include
excluded.
many procedures. So those are completely off limits.
Right, I got that.
Yeah.
That I'm clear on. But what is left, I mean, Brian was saying there are thousands of procedures left. Well,
Right.
what are the areas that they would feel that we could come to agreement, or areas that people are comfortable with the optometrist doing some form of surgery?
But it still comes back to the same question that the chair's been asking, whether it's more or less procedures. The question is whether people are adequately trained to do them. And, it doesn't matter to me what they are necessarily. I mean, it's a question of adequate training, yes or no. And I think that's something that it's hard for us. It's clearly something we're grappling with. And I think it's legitimate to be grappling with it. I kind of feel like we just need to spend more time talking it through. I mean,
Yeah.
I
think, and I will say this is going to probably reveal more than you want to know, but I, many years ago, had a tubal ligation. My primary care doctor could not do it. Even though he was trained, he performed them. He was a Doctors Without Borders kind of person and all that kind of stuff. And he did them many times. But because the hospital had surgeons on staff, he was not allowed to perform that because it was considered surgery. So it was considered outside of his scope of practice, even though he was well-trained and adequate to do it. So that's my concern here, is that we should just be looking at the training. Is it adequate or not?
But if you haven't identified the areas of practice, I guess that's sort of what I'm hearing. If you're haven't identified the areas you are asking to do procedures in, how do we know that the training is adequate? I guess
what we can say, the areas, I guess then what we would do is not the particular procedures, because we don't want to list 1,000 of them.
No, but areas.
So as we have areas that will not be ventured into, we could have areas that are.
That's what I thought I was.
I thought you wanted to list all the 1,000.
No. We talked about 17 areas where that we were excluding, but maybe if we began with areas that we would include and felt comfortable including and felt the training was adequate, which is absolutely what we're after, then we could proceed and begin and progressively add those areas in.
You just have to remember, though, that's what OPR did a couple of years ago. There was a similar bill, but it talked about procedures that they could do. And OPR came to the conclusions they came to. And so we've already done that. Senator Clarkson, a couple of years ago, tried to draft a bill that we could adopt that would list the procedures they could do.
Not procedures, areas of practice.
Well, I don't know if they were areas of practice or if they were the
Lauren,
actual.
maybe
procedures.
Lauren could, and Dean could answer that. I don't.
Yeah, Lauren.
For the record, Lauren Hibbert, Director of the Office of Professional Regulation. Thank you for having me here today. The report does list specific procedures that the optometrists were looking for. And I just would like to ground this committee. I hear that there's concerns about the report. I'm happy to testify to possibly why there's some concerns about the report when it's my turn to testify. But the report does specify the procedures that the optometrists are looking for. And I can talk about this more when I have a more expansive time to testify. But given the two drafting approaches, and this is absolutely no criticism of Ledge Council, OPR would prefer a list of authorized procedures versus a list of exclusions. And the reason is that's much easier from a scope of practice determination, whether someone's operating inside or outside of their scope. A list of authorized procedures would be much better. Recent scope expansions, which we, OPR generally supports, have included express authorizations as opposed to a list of exclusions. So that would be OPR's preferred model for addressing this issue.
So could we get a draft of that somehow? I don't know if that would be
a draft of the
OPR's
report.
No, the list that was in the original bill, I guess, is what, because that's what you're saying, right? It was in the original bill, the list of things that were being looked for. So
it was in the original bill, and it also was in OPR's report. There was a list of procedures.
Okay, so we can look at that and have a discussion about that. Okay, great. And I did read the report, but I must admit it was a year and a half ago.
I will resubmit it to your committee.
I bet Gail has it posted, and thank you for sending it to me earlier, Lauren.
So committee, are there any more questions today, concerns? I do think that this is at any time we have, and I will acknowledge Lauren's comment here about scope of practice, is at any time we have a change in the scope of practice, there are tons of issues that come up, and it is hard decisions. And in my history here, we have only rolled OPR once, but we did it once, and it worked out well. Did it not? It was landscape architects.
Landscape Architects has worked out well.
It has worked out well.
And in my days.
We'll just also note for the record that we've never had a complaint about Landscape Architects to my knowledge. So the public protection element may not be present, but that was OPR's position back then.
Well, the engineers told us that we would have walls falling down and parkways disintegrating and but okay. Okay, committee, I'm going to suggest that I have, because we have to do our scheduling, I've already scheduled next week is already full, so it would be the next week, and I'm thinking where do you guys, where are you here? 158. I'm thinking of perhaps Tuesday the 8th. Does that work for anybody who wants to come? It's going to work for the committee because they have to be here regardless of what we're doing. So, and we will make sure that the invite goes to everybody who's here today, whether you want to join us or not, or just sit in your office and listen with one ear and work with the other ear. And when you hear something, pop in, but we will send you the invites. And if anybody has any suggestions going forward that might help us here, please let us know. And that is everybody.
And so are we going to get some of the information we just asked for, I hope, other than from OPR? Is it sort of more statistics about the states, the procedures, anything else?
If we can ask for that.
Yeah, we would, I think some of us would appreciate seeing that.
Yep. I'm sure that.
But we are cognizant, Madam Chair, that we are looking at, are they adequately changed to do the procedures? And I think Lauren's point is well taken, which is, how do we know if we don't know what the specific procedures are?
Yeah, no, that's different than asking for that. And we will get some information from the other states. I'm sure that is there. I can't remember if it was in the materials that were sent to us.
I couldn't remember the chart Heather sent this incredible resource, but I will look again, but I didn't see that chart, but
No, I don't know that there was one. But we can get some of that information.
All the states, yeah.
We can get some information from the other states. And we can also, if anybody has a suggestion, we talked about recent grads during people who graduated in 1960, and if there is some kind of a cutoff point, and should that be implemented? And I think you weren't here when we talked about that, Senator Clarkson, but if somebody graduated in 1960, they're probably not still practicing, but on the off chance that they are, would they be qualified to do this, and would just continue education courses or some other course be adequate, or where kind of is the cutoff point? And we heard from Dr. Hitchmuth that she graduated in 1995, I believe you said, and that you had the training then. It was so.
And Dean got it, and he graduated in 2009, as I recall.
Well, yes, but she was saying that they were getting the training even in 1995. So.
Well, hence some of these states having done it for 20 years.
Yeah.
I got it. And,
Madam Chair,
yeah,
I just want to say, I don't think you've shortchanged other things to this point, but we have language access and policing oversight and temporary employees and corrections.
I'm getting them listed.
I just hope that day we spend on this issue is potentially the last, and we get the information we need, and we don't belabor this, because I don't really know what the resolution would be if we keep taking testimony on this.
Well, I am scheduling things here. I have both language access and planning office on the schedule for next week. And I have APS, and I have the ethics. So I am trying to schedule everything that we've talked about so far.
Okay, when we take up Agency of Public Safety, I'd really like to be able to address other policing oversight issues that are reflected in the bill that we got from Judiciary.
Yep, and we will. We will. We have about 6 weeks left, or 5 weeks left before crossover, and we will address all those issues.
Yep, we're looking forward.
I'm trying to do my best here.
You're doing a great job, and we are getting through a lot of different material, from eyes to ethics. The 2 E's. This week has been an E week.
Okay, so, and I think that what I'll try to do is tomorrow schedule a little time for us to look at the bills that are left and what are priorities that haven't been scheduled yet.
Thank you.
Okay.
And thank you all for, this is the wonderful thing about Zoom. We have you from all over the place, and we couldn't, 2 years ago, we wouldn't have, we'd have had you by phone, but it's much more exciting to see you in person.
Yes, thank you very much. And we'll